Hello, everyone. Thank you for joining us today. Welcome to our webinar, Reduce Time and Overhead, Streamlining the Intake Function to Optimize Revenue Cycle Operations. We'll give folks just another minute or two to keep, I see a lot of folks still coming in, so we'll give folks a chance to get logged in. I know you're all busy. So we'll give folks a minute to get situated, then we'll get started. We have a lot to cover in a half an hour. All right, looks like the participant pane is leveled off. I think we've got most of our folks in here. So good afternoon or good morning, depending on where you are in the country. Again, welcome to our Symmetry webinar, Reduce Time and Overhead, Streamlining the Intake Function to Optimize Revenue Cycle Operations. My name is John Rabbia. I am a director on our operations consulting team, and I am joined by my colleague, Camala Mueller from Growth Solutions. We have a half an hour today to cover a lot of ground with you. We want to make sure that any questions that you have get answered. So please make sure to use the Q&A function. If we don't have an opportunity to answer your question live on the webinar, we will certainly make sure that we get a response to you via email. So we'll take care of that. Additionally, I know one of the most frequent questions that I typically have when I'm attending a webinar, and one that we often get, is will you be sending out the slide deck? And the answer is yes. We'll pop it in the chat box before we finish up today so that you can download it, but we'll also be sending it out afterwards. So not to worry there, you will be getting the slide deck for today. So let's get rolling. Just real quick before we get too far into the content, want to remind everyone that Symmetry has a whole breadth and wealth of services in the post-acute space. Pretty much anything you might need help with in your organization, we have a solution for you. So if there's something that is keeping you up at night, please don't hesitate to give us a call. We'd love to talk through it with you and help you resolve your issues, whatever they may be at your organization. So without further ado, we'll talk about our objectives related to today. So we want you to walk away from today understanding how to maintain an optimal customer experience for consumers and providers throughout the life of a referral. And we know that a lot of that lives in the intake department. We want you to be able to walk away understanding how to manage the intake process effectively for achieving patient outcomes and ensure that your intake workflows include all of the components of both the clinical and financial requirements to process claims, so that we're providing excellent quality patient care and also keeping our revenue cycle moving along efficiently. So this little graphic kind of frames up some of the magnitude of what we're talking about today. This is the post-acute revenue cycle. And as we can see, it really starts in intake. We are collecting some of the really vital information that's necessary to drop a claim timely and to have it be processed without any sort of rejections or denials. The pieces of the revenue cycle that fall into intake are that initial collection of information and referral management process, verifying the insurance plan or plans, gathering authorization if that's required by the payer, and then moving on to being able to actually schedule that patient in a timely manner to get them onto service. So it really is setting up the whole rest of the clinical operation and the revenue cycle to function effectively. And with that, I'm going to hand it over to Cami to talk us through a year in the life of a patient.
Thanks, John. So while it's so important, the total revenue cycle that John just shared with you, and we're going to take a look at each of those pieces and all the different departments and players that come into play, it's important for us to always start with that patient and think of it from that patient perspective and keep that perspective as we go throughout the process. And so here we have this wonderful visual of what it truly looks like for a patient who is appropriate for home health and even maybe becoming appropriate for hospice. and what a year of their life looks like. And so while you may not see too many surprises here, I just want to call out and make sure that everybody understands that this is truly what their life looks like. And so it's not unusual for them to have been in the hospital for every other month for this past year, probably been in a skilled nursing facility or some type of community a couple of times, and had a couple of different home care agencies, but also, excuse me, I think it's important to call out that this, to look at the fact that they've had 16 different physicians, several different therapists and social workers, and, even 37 nurses. And while we all know that everyone involved is well intentioned, that a lot of times there's not a lot of collaboration, and sometimes even different messages about how to manage the different chronic diseases that this patient is going through. And so when we look at this, I like to go ahead and give this patient a name. I'm going to refer to him a little bit more. And so we're going to call him Mr. Earl. And so just again, thinking about putting yourself in the shoes of a patient like this, like Mr. Earl, and what that's like, helps us to think about what intake really is and what's important when we're thinking about the intake process. And so we're going to just reframe our thinking a little bit more here as far as what those customers look like. So of course, we have patients and families like Mr. Earl. And so when we think about working with them, whether it's on the phone or electronically, digitally, we have to remember that this is possibly the most difficult time, the most difficult phone call, if you will, the most difficult part of their healthcare journey that they have to encounter and process at this point. And so when we put ourselves in their shoes, we have to think about how they are feeling and remember what kind of year they've just had, just like we saw in the previous slide. Other types of customers we're going to think about putting ourselves in the shoes of them. And so referring physicians that we're working with, again, whether it's on the phone or digitally, we need to think about what their life is like, making sure that their day is scheduled properly with all of those patients while they're still getting phone calls and prescription refill requests. And so whoever we're working with in that physician office, we need to remember that their life is very busy. And so while our lives are busy as well, working through this intake process, we need to remember that their lives are busy and make it as efficient and effective as possible. Same goes for the hospitals. Though more than likely we're working with case managers in the hospital or someone that's working with getting that patient discharged to a safe level of care. And so that is what is keeping them up at night, if you will, where they are under very much pressure to get those patients out of the hospital so that there are beds to be freed up. Working with customers within skilled nursing facilities and assisted living communities, we need to think about the fact that they're concerned about keeping those beds full. And so that's the framework that they're coming from as they're working with you and your intake process. And so you need to be, whether it's whatever part it is of that intake process, we all need to be thinking about what their life is like and helping them to make it easier to keep their patients in their beds. And then finally, there are other people within the community that we may be working with. And we need to also be thinking about what our brand looks like within the community, how we are representing that when we are interacting with all of these different consumers. And so as those, again, phone calls come in or different consumers that you need to work with within the intake process, what are their pain points? Thinking about what is most important to them. And then as we go into thinking about the process that we have to distinguish that these aren't just our one person. If you're a very small organization, maybe doing all of these different tasks, or you may have all of these different departments. And so while we do have those different departments, this truly is a process. And so everyone in this process has to be able to work together. Those business development representatives or sales representatives and clinical liaisons have to be able to have a good relationship with those in the access department so that they can support one another in whatever is needed to get that patient through to the actual admission process. Insurance verification has to work again with access in order to make sure that all of their parts of the process are done in order to be able to get the patient admitted, working with clinical operations smoothly, so that, and revenue cycle and finance, so that the patient can be admitted in a timely manner. Throughout all of this, customer experience has to be the most important thing that everyone is thinking about. So we talked about putting ourselves in their shoes. Again, those patients' families and their loved ones are often under duress. And so it's important to think about what their experience is, what their perception is as far as your interaction with them all the way through the process. It has to be easy for all of those referral partners to do business with you. It has to be simple for your staff. If it's simple for your staff, then it's simple for your referral partners. And the way to do that is to make your process efficient and streamlined. So be sure to really look at your process so you make sure that there is not duplicative work. So many times we create spreadsheets outside of the EMR, which end up truly being a duplication of what can be managed in your EMR. So making sure from that standpoint that it is streamlined and efficient so that your team is confident in being able to provide a very efficient and simple process for your referral partners. And at that, I'm going to hand it over to talk about the whole process to John.
Great, thanks, Cami. So within the context of understanding that there is a human being who is at a pivotal and challenging moment of their lives, and we want to provide all of this excellent customer service, we need to make sure that our first step is to efficiently and accurately capture the data that we need to get started and move forward. And that starts with patient demographics. I'm going to be clear, it sounds common sense to say so, but it's worth mentioning that we have the patient's real name versus if they go by a nickname, and understand what the patient prefers to be called versus what we're going to be able to put on an insurance claim. So capturing accurate name, date of birth, the address, and again, confirming what's the patient's actual residence versus if they might be going to a friend or relative's house to receive their care. So differentiating those two data points. Capturing not just their primary insurance, but all insurances and policy numbers so that that can be verified. And we can determine what order to bill our services in. Probably one of the single most important items that we need to capture upfront in intake is which physician is going to be following this patient and signing our orders. And very often that physician is different from the provider who is referring the patient. So we have occasionally if it's an ambulatory care referral, it might be the same provider who's referring and will continue to follow. Very often, if the patient's coming out of a facility, we have one provider who is referring, but a second provider who's actually going to follow the patient and sign. We need to verify that. We need to make sure that that provider is going to agree to sign orders. I don't know how many times we've called to follow up on orders and found out that provider who we were banking on hasn't seen that patient in 18 or 24 months and isn't going to sign anything until the patient's been in. So it's the kind of work that we want to make sure that we're capturing accurately. diagnosis codes, or at least enough referral documentation so that whoever is doing the coding can accurately and thoroughly and completely code the chart down the road. We need to understand our benefit period on the hospice side and certification period on the home health side. Again, sounds intuitive, but if we have a patient who's been on service with another home health agency and is coming back to us within a 60-day period, we might end up with a partial episode payment. We want to understand that. If it's a hospice patient who has been on service with another agency for 2 benefit periods and they're entering their 3rd, we're going to need a face-to-face documentation. So really understanding where that patient is in terms of their cert periods and benefit periods, depending on if we're talking about home health or hospice. And then of course our referral source, so that we can make sure that we are communicating back that the referral is accepted, that the patient's on service or not. If we run into trouble, if we're having a hard time finding the patient, we need that so that we can close the loop from a communication standpoint. One of the things that will help us capture complete information is having some sort of a checklist. And to Cammie's point about making sure that we're leveraging the EMR, ideally this checklist should be within your medical record system in the form of either a template or hard stops, and not in a notebook somewhere or in a spreadsheet somewhere. We want to make sure that we have as much of this streamlined internally within your EMR as possible, and leveraging the full capabilities of your system to make your lives easier. And what we need to do here is we're looking at these different data points is discern what is need to know and what is nice to know, because we want to make sure, we'll talk about this in a moment, we want to make sure that we're not delaying patient care if possible. We want to make sure that we're making this process as easy as possible, both for the patient and their caregivers, so that they are not feeling like they're in limbo, but also for our referral sources, so that they're getting a quick answer. They know that their patient is taken care of, that there's continuity of care, et cetera, et cetera. So we need to make sure that this is easy and efficient. So determine what is it that you absolutely need to get a referral started, and then what is it that's nice to know further down the line. So we're certainly going to need to know if the patient's in our service area, if the patient's insurance is a plan that we accept. We're going to need an order to do what we need to do. From there on out, it would be good to know who the physician, to confirm who will follow the physician. Your agency's risk tolerance will determine whether or not you are willing to accept a home health referral without an existing face-to-face encounter. Mind you, we have 90 days before or 30 days after the start of care. It's always nice, it's best to have it beforehand, so that we will be certain that we've met our requirements and we can bill. Sometimes, if you can swing it and the patient doesn't have a face-to-face encounter, or what you do have isn't going to meet the requirements, if you can still accept that referral and then go ahead and get the face-to-face down the line, you want to have a very tight process around that. Again, making sure that their doctor's appointment is scheduled, that you have a system in place to make sure that the patient actually goes to the appointment, and then that you have a process to get the documentation so that you can meet that 30-day timeline. So be very, very careful around that. Then the other items, in terms of your referral documentation information that's helpful for whoever the clinician is going in to do your admission visit or your start of care visit. Other referral information, including the discharge summary, physician notes, history and physical, progress notes, labs, med lists we're certainly going to need, advanced directives, and other referral demographic forms. So determine need to know versus nice to know as you're designing your workflow and your hard stops. Keep in mind that you may or may not have a sales team or clinical liaisons that you can lean on. These folks are obviously our primary source of new referrals. They're out with the relationships with the referral sources, talking to them every day. They are the folks who can also help make sure that we get appropriate information up front. They can be the folks doing education with our physicians, providers, and referral sources on what we need in order to safely and efficiently serve their patients. If we're talking about, what needs to be on a face-to-face, or why we need a discharge summary, or why we need acceptable diagnosis codes, or the type of documentation that we need to support those diagnosis codes. So your liaisons can leverage the relationships that they have with those referral sources to do a little bit of education. We don't want to nag and hound them. Again, we want to make this as easy and painless as possible. But if they can just give them a brass tacks education on what we need to help serve their patient the most efficiently, that's definitely going to help you. And we can also leverage these folks when we're missing face-to-face encounters, or if we need to get plans of care and interim orders signed. If they're not coming back through your typical means, like through fax or portals or however it is that you're sending out your orders, we can always leverage our sales and liaison folks to give a friendly nudge and get those documents back and signed so that we can bill. So some of the impacts that intake can have on patient care, we mentioned this in the previous slide, are delays in care. So if we don't have enough documentation to safely see that patient, if we don't have enough documentation to send a clinician into that home prepared, that could potentially lead to a delay in care. If it just takes too long because of our intake processes to process that referral, to verify insurance, to get everything that we need on deck, to hand that off to scheduling, that can lead to a delay in patient care, which could, well, certainly is going to be a dissatisfier to our patients and referral sources, but could potentially lead to that patient ending up going back to the hospital before we even get started with them. So we need to make sure that we are as efficient as possible. To that end, that will help the folks who are working in our intake department meet the productivity expectations that we set for them, so that we can make sure that we're maximizing our resources from an administrative side. And again, the more efficient they are, the easier the process is for them, the easier and more satisfying the process is going to be to our internal stakeholders. So the folks who are scheduling the admission visit and carrying out that admission visit, and to our external stakeholders, the folks who are actually making the referrals to us, as well as our patients and their caregivers. So we want to make sure that we're hitting all of those nails on the head with an efficient process, so that we can optimize our patient and caregiver experience, and hopefully that will translate into higher patient satisfaction scores. So we have here some productivity metrics. Again, this slide deck will be going out so that you can have this as a reference, and what are at least a starting point for industry best practices for a liaison nurse, a clerical intake worker, a clinical intake worker, on the hospice side, insurance verification and authorization. You'll see there's ranges, there's referrals plus managing calls per day, because that's just real life. We don't all have the luxury. None of us have the luxury of not having to answer a phone. So we're having to do our work and answer calls. So these are a starting point. And as we mentioned on the next slide, it really is highly variable, depending on what your workflows are, what your referral sources are, the types of patients that you serve. So great, we can move on to the next slide. Thanks, Andy. So impacts of intake on the revenue cycle. We talked about some of this before, but if we have incorrect patient information, address, insurance number, date of birth, name, we're going to get rejections and denials, and it's going to slow things down as we verify that information, correct it, and then resubmit. So we need to make sure that we are getting that correctly up front. Also, not getting adequate referral information up front is going to lead to delays in being able to accurately complete the OASIS. We're not going to have the codes, we're not going to have the clinical documentation to support our OASIS responses. So very important that we're able to get that information up front to set everyone up for success in terms of completing that. And more on potential delays on the revenue cycle. If we're missing that face-to-face encounter, we talked about that. We're going to have to hold up billing until we get that. We only have a 30-day clock after the start of care to get it. So we need to make sure that we are optimizing that process and that we have tight workflows in place for that. And we discussed as well having the correct physician so that we can send those orders to the right person the first time and get them back efficiently. Need to make sure that we have the right admission source from a home health standpoint. So institutional versus community, it's going to have a big impact on the revenue that we can expect from that episode. On the hospice side, we talked about making sure that we're identifying if that patient has been on service with another agency so that we know what benefit period we're in, and if we require a face-to-face to support our care. So either of those could have huge impacts on the revenue cycle on both home health and hospice. All right, we have about 4 minutes left. Wanted to leave a few minutes to get through some questions if you happen to have them. So feel free to pop your questions into our Q&A box, and we will make sure that we get you answers. While I'm chatting, we do not have the ability to put our slide deck in the chat box, so we will email that to you. You will get it shortly after we log off today. All right, well, if we don't have any questions, we can give you folks 2 or 3 minutes back in your day here. We'd like to thank you for joining us this afternoon or this morning, depending on where you're coming in from. And again, please let us know if there are any issues that we can address with you to help your agency run better.
Thank you.